I am discussing the topic of ALL and CLL findings. Introduction to leukemia is acute leukemia and chronic leukemia. Acute leukemia is characterized by rapid, uncontrolled proliferation of immature lymphoid progenitor cells in the bone marrow. It requires immediate medical intervention due to bone marrow failure. Chronic leukemia CLL defined by slow accumulation of mature appearing but immunologically dysfunctional monoclonal B lymphocytes. Often indolent patient can remain asymptomatic for many years. Pathophysiology of ALL is marrow infiltration and systemic spread. In the marrow infiltration, malignant transmission of lymphoid progenitor leads to rapid clonal expansion. This blast crowd out a normal hematopoietic stem cell causing severe pancytopenia. In the systemic spread, immature lymphoblasts readily spill over the bone marrow into the peripheral circulation, subsequently infiltrating secondary lymphoid organs and the central nervous system. Pathophysiology of CLL is a defective apoptosis and niche accumulation. And we will discuss the topic about acute lymphoblastic leukemia in a very detailed manner. And ALL peripheral blood smear is marked lymphoblastosis. In the marked lymphoblastosis, peripheral smear typically reveal high number of circulating immature lymphoblasts representing the malignant lineage. Immature nuclear chromatin. Blast nuclei exhibit fine, delicate or lace-like chromatin patterns reflecting high transcriptional activity and lack of maturation. High NC ratio cells are characterized by an extremely high nucleocytoplasmic ratio with only a thin rim of basophil cytoplasm visible. Inconspicuous nuclei are usually absent or few, often small, distinguishing them from the prominent nuclei of myeloblast. Fab subclassification of AL is L1 subtype and L2 subtype and L3 subtype. Visualizing all ALL on smear, predominance of large lymphoblasts with high nucleocytoplasmic ratio. There is a fine open nuclear chromatin with distinct nuclei visible in some of the blasts. Marked reduction or total absence of normal mature red cells and platelets in the background. There is an absence of outroads which helps in morphologically differentiate ALL from AML. ALL bone marrow finding. There is a severe hypercellularity. Bone marrow aspirates and biopsies typically reveal extremely hypercellularity, often approaching 100%, completely packed with blast. There is a diagnostic threshold. There is a presence of more than 20% of lymphoblast in the bone marrow in the official WHO diagnostic threshold for acute lymphoblastic leukemia. Suppression of normal lineages, marked reduction or complete absence of normal erythroid, granulocytic and megakaryocytic precursors. Dry trap grease. Due to dense packing and reticulin fiber deposition, bone marrow aspiration may occasionally result in dry tap requiring a core biopsy. ALL marrow histopathology. There is a diffuse blast infiltration. The bone marrow core biopsy section reveals complete replacement of the normal marrow fat and multilineage of hematopoietic cells by a monotonous sheet of tightly packed lymphoblasts. There is a minimal to no residual normal hematopoiesis directly correlating with the patient presentation of anemia, thrombocytopenia and neutropenia. ALL immunophenotyping. There is a B cell lineage ALL and T cell lineage ALL. And now we will discuss topic about CLL, chronic lymphocytic leukemia. In the CLL, there is a peripheral blood smear, and we will discuss about absolute lymphoblastocytosis defined by a persistent by a persistent absolute lymphocyte count more than or equal to 5000 mcl in the peripheral bloods composed of monoclonal B cells. Monotonous morphology. Smears are dominated by small, mature appearing lymphocytes that are remarkably uniform in size and shape. There is a saucer ball chromatin. Nucleus possess heavily clumped and dense chromatin, creating dark and light patches resembling a saucer ball or cracked earth pattern. There is a scanty cytoplasm. Each lymphocyte has an extreme narrow, almost impracticable rim of pale, non-granular cytoplasm. Smudge cell phenomena. There is a 30% typical smudge cell ratio. Mechanically, fragility of CL cells are smudge cells are ruptured, flattened nuclei of a lymphocyte lacking a defined membrane. Because of malignant CLL lymphocytes are highly fragile, they easily break open during the physical shearing of preparing a blood smear. This is a classic pathognomic hallmark of CLL. Adding a drop of bovine albumin to blood sample prior to smear preparation can stabilize the cells to allow an accurate differential count. Visualizing CLL smudge cell. There is a abundant small mature lymphocytes with a dark and heavily clumped susceptible nuclear chromatin, which are seeing in a diagram. Numerous amorphous disrupted smudge cell. Minimal background cytopenia early in the disease through severe anemia or thrombocytopenia can develop in advanced stages. CLL bone marrow infiltration is a nodular pattern and intestinal pattern and diffuse pattern. In the nodular pattern, there are aggregates of mature lymphocytes localized primarily in the non-parotopical phases, associated with early disease stages and favorable clinical outcomes. Interstitial pattern is lymphocytes infiltrate the interstitium surrounding but not replacing normal fat cells, and hematophysis typically suggests slowly progressive disease. And diffuse pattern, lymphocytes completely replace the fat and normal hematophatic elements strongly associated with advanced stage anemia, thrombocytopenia, and prognosis. CLL marrow histopathology is there is a core biopsy shown an extreme lymphoid infiltrative composed of small, mature, and round lymphocyte with a condensed chromatin. There is a staining highlights of clonal population of CD20 and B cells with aberrant expression of CD5 and CD23, cementing with pathological diagnosis of CLL. And CLL immunophenotyping is the CD5 B cell expression, dim surface markers, and light chain monoclonality negative markers. And we will now differentiate between ALL and CLL. And in the ALL, dominant cell type is immature lymphoblast, and in chronic lymphocytic leukemia is small, mature, appearing lymphocytes. In the acute, cell size is large, and in chronic, small. And in chromatin protein pattern in acute is fine, delicate, and open, and coarsely clumped in the chronic. And nuclei in acute is inconspicuous, and in chronic is absent or rare. Smudge cell rare or absent in acute and abundant in chronic. Bone marrow blast is more than 20 blasts required for diagnosis, less than 5 to 10% lymphoblast required for chronic lymphoblastic diagnosis. There is a diagnostic flowchart in which CBC and PBS smear is done, immunophenotyping is done, bone marrow examination is done. Thank you.